Hello, everyone. Good evening. Good evening, wherever you are. Good afternoon.
Yeah,
But
I'm not sure.
we're joined today with Dr. Hanish Patel. Dr. Patel is an optometrist. He owns his private practice, a large private practice in New York City, in the heart of Midtown New York City. He is an expert, I say, because he's been doing this for a while. He's been doing dry eye disease for a while. He has an InMode, which is what he utilizes as one of the instruments, many instruments, and he'll talk a little bit about his practice. But I've gotten to know him over the last few years, and I think he's really a good speaker because he articulates what we're thinking, and he answers sort of the questions in a way that's really reasonable and thoughtful. And he has a lot of good conversion. There's a good, very successful business and practice serving people in New York City. So thank you for joining Dr. Patel today, this evening.
Yeah, thanks for having me.
Of course, of course. So my name is Bob Miglani. For those of you I don't know, please do, by the way, drop a question, a chat. If you can hear me, great. If you can't, well, you got to let me know some other way. I don't know. Maybe you can't, I don't know how it is, but with the chat, if you have questions, drop them in here. What we're going to do today, I'm going to share my screen a little bit. And we're going to go right into it here. Okay, so we're going to share today. Let me see here. Dry eyes. It's all about dry eyes today. It's all about dry eyes, folks. So here we go. Here we go. Here it is. Okay, so it's guide to boosting conversion for dry eyes using InMode Envision IPL RF. Uh, Obviously, any of the content that we're sharing with you today is applicable to other instruments you have, certainly, right? Luminous IPL, RF, OptiLight, OptiLift, etc. There's so many instruments today, but the goal here really is to help walk you through how to convert more patients and into dry eye treatment. A little bit about me. This is my wife's practice. Some years ago, she had a cover on it, and it really upset me. I was like, I'd walk by the bath towards the bathroom, and this cover was on it. I was like, what is going on? How come we're not doing more of dry eye treatment? Because it pissed me off because, the mortgage, you're writing a check every month and you're like, we have all these patients for first visits. And then, this many are prospects for dry eyes, and the signups were like down here. So we were really, really frustrated with a lot of potential revenue in the practice, and equipment was just gathering dust. And so it was like, what do we do? What do we do? And then we came upon this journey to help really understand how best to convert more patients for dry eyes. And we got a chance to meet really good, thoughtful experts like Dr. Patel. So I'm going to talk, this is what we're going to talk about. This is what we covered. Dr. Patel, why don't you give us a little introduction to you, just briefly, just a little bit about, who you are, how long you've been doing this, just give a sense to the audience here, what you're about.
Yeah, so I'm, as Bob mentioned, I have a practice in New York City. I graduated from SUNY a number of years ago. I've basically been in practice pretty much my whole career. I did a residency in disease and then joined a group private practice where I was at for a number of years and then eventually left and started my own practice. So our practice turns 8 years old in a few months. And we really set out to differentiate ourselves as much as we could in the market. New York City is a very competitive environment, and so anything we could do to differentiate ourselves. So we invested in our practice to make it look modern, to make it feel modern, have as much high-tech equipment as possible. We do a lot of imaging. I'm sure we'll talk about imaging in a little bit, but and then we really started to look at, well, what are the specialties? What are the things that we should be offering to our patients, again, to separate ourselves, right? Yes, we have a busy routine practice with soft contact lens business is good. We actually do quite well in our optical, but really, our main focuses in the practice are specialty contact lenses. So we do sclerals, ortho-K, myopia management, and dry eye, right? Those are our main focuses. We also have a separate, completely independent clinical research center. So we do clinical trials and anything eye, medical devices, pharmaceuticals, and contact lenses and other things. So that's kind of our practice. And we kind of set the goal to get into that from the very beginning, and we opened in 2018, and by 2020 we were purchasing a bunch of equipment to help us in the dry eye journey, and then we kind of continued from
Yeah.
there.
Amazing. Thank you for that. At some point, we should really talk about the clinical research part of it as well, because I'm sure the audience is also interested in looking at clinical research, doing research in their clinic. But tell me, why did you get into dry eyes? Why do you think dry eyes is a good specialty to get into for optometrists today?
Well, we got into it because we just saw a massive need in our practice. I mean, again, this was we opened in 2018. 2020, we know what happened, and then really we started to see. We were already seeing quite a lot of dry eye, but we really started to see dry eye ramping up in 2020 and 2021 with COVID, work from home, screen time increases, all those kind of things. And so we had, we couldn't let the patients walk out of our office. We needed a solution. And so we really started looking at what was available. We brought in an IPL device, a different IPL device at the beginning, and then thermal device with a meiboflow device for thermal treatments. I've always believed that you need both things. You need some type of light-based treatment and some type of thermal treatment. The two things kind of go hand in hand. And so we kind of were working with that for a little while, and then a couple of years into that, we kind of weren't super happy with our thermal treatment, and the IPL was kind of okay. And that's when we kind of did a bit of a search, and we really wanted to bring in radio frequency, and that's kind of where we landed. And so, we always wanted to maintain in our practice to do dry eye, but do it the best we can, right? So the best technology, the best option, which really helps when you're talking to patients. If you can be confident that you're offering them the best treatment for their condition, then you can be honest about that, and then it all starts with being honest and clear with patients. And so dry eye is a massive need. It's really an optometry thing. There's very few ophthalmologists that are doing this, so it's very much in our wheelhouse. And the number of patients that you're seeing, the percentage of patients that you're seeing in your practice that have some form of dry eye is very, very high. And they're already in your chair. So you don't have to market outside for this. You definitely can. You can grow that way too. But if you've got 15 to 20 patients coming into your chair every day, it's an easy specialty in a way to help convert over.
I love that. I love that. I love the fact that you pointed to the need first, and then you look at it and you say, well, what's the lift? The lift is really the equipment piece of it, and then understanding patient communication, because it's really they're coming in already. The patients are there and they're not being converted. Walk me through I just want to, this is a numbers exercise. Just walk me through, let's say we have 250, let's say it's 250 comprehensive exams a month. I know I don't want to, I don't need to know
Yeah.
your numbers specifically, but if you say, what percentage of those who come in might have dry eyes? Would it be 20, 40, 50, 60? What are we talking about?
I mean, I think it's probably significantly higher if you look at our
Yeah,
population in
yeah,
Midtown. But yeah, I think if we conservatively, I think we could conservatively say, 40%. I
40%.
mean,
Okay,
if
okay.
we,
Yeah.
I think that would be fair. I think there's probably the total number is probably more.
Yeah, okay. And then you have a certain percentage that either, in Midtown, you have a little bit of a different philosophy, because a lot of times patients just want to like sign up right there, which is great. But a lot of times they do come back for a follow-up ocular surface evaluation. Would you say, generally speaking, let's say 50 is 50%, or 40 of them would come back, generally speaking? What do you think?
Yeah,
30?
maybe right. Again, I think it depends. What it really depends on is, how busy our day is and
Yes.
how quick we got that communication to the patient about dry eye, right? So that's gonna affect this little ratio here for sure. But yeah, 40, I think 40 to 50% will probably book and immediately and come back. And again, I would say that's probably the majority of the symptomatic ones. It may even be more than that actually.
Yeah, and then if we say, let's say 30 of them, maybe 20 of them sign up, and if
Yeah,
it's, let's say $2,200, I'm just, as again, just a roundabout number, $2,000, that's $40,000, right?
yeah.
$40,000 and a new, I mean, that's per month. That's a very significant revenue share that you can, that is possible. Is that
Yeah,
a
and I think
fair estimate, you think?
I think that's a very fair estimate. I think it takes I would say it takes a little bit to get to 20, but I think if you get to 10,
Yeah.
which I think is very reasonable in a very quick period of time. I mean, we're talking two a week, three a week. I mean, this is not that many patients to get in a month. And what I think one thing to really keep in mind, so I mean, if you say that's, I don't know, $400,000 in revenue, right? If you say in a month or $500,000 in revenue,
Yeah.
this is service-based revenue, and I think that's something that oftentimes we shouldn't overlook. And I know not all optometrists, and me included, are good business people, but when we look at service-based revenue, this is something that we are professionally providing to a patient, and it doesn't really have a cost of goods associated with it. Now, again, this may be device dependent if you have a click fee on your device, or
Consumable
if you
or
have a
whatever. Yeah.
consumable on your device, right? So
Yeah.
again, that's depending on what device you have. But if you have a device with no consumables, most devices we're talking, a little bit of ultrasound gel and a tongue depressor and some tissues. It's let's say you're talking cents of consumable cost, right? So there's obviously clinical time, maybe technician time, but ultimately that revenue is going straight from your top line to straight to your bottom line, right? On your
Yeah.
profit. So
Yeah.
I would much rather do $500,000 in dry eye treatments than sell $500,000 worth of contact lenses or glasses, where the cost of goods is going to eat into that big
Yes.
chunk, right?
Yes.
So
Yeah.
so
Very good point.
it's when I talk to people about practicing this, it's really important to understand how much effort you want to put into growing this in your practice, because your payoff is significantly higher for that revenue.
Yeah, that we had a doctor the other day recently we spoke to, and he said, well, I bought this machine, I have this equipment, but there's a little time to do dry eyes. And he's just tired of the insurance plans, right? He's just sick and tired of getting whatever, 40, 50, 80 bucks, whatever it is for comprehensive visits. And he's just got lots and lots and lots of patients. So he bought an IPL, and he's just like, yeah, but the time required to get into dry eyes. And I said, well, you're spending that same time getting less than $100. But here you're getting 10x. You're getting 1,500, you're getting 1,600, you're getting $2,000. So the lifetime value of the patient is very high. So it's very frustrating. So why is it? Let's go to the next question. Why is it so hard, Dr. Patel, for many optometrists to run a successful dry eye practice?
I think it's hard to start a successful dry eye practice. Once you start, I think most people are quite successful. But starting it is difficult, because we have to change our mindset, right? We have to change a lot about our mindset of how we practice, and
Mhm.
how we fundamentally think about dry eye, right? I think that's something, if most of us went to school a little while ago, and I always felt like we ran away from the dry eye patients, right? Even in school, we would see a patient and we'd go back to our attending and say, oh, by the way, they said their eyes are dry, and they'd say, oh yeah, just grab whichever artificial tear we've got, whatever we have, whatever sample we have in the closet, give them that bottle and tell them to just use this, and then get them out of here,
Yeah.
and and again, this is kind of right when like Restasis and things are coming out. So we just didn't have that many options for them, back then, right? And so that's kind of how we got trained, right? We practice the way we train to some extent, unless we really change what we want to do. And the patient would come back next year with that same sample bottle and say, oh yeah, this ran out. Do you have more? And it was like, well, did we do anything for this patient? But we didn't really have anything for these patients, right? And now we do, right? So we have to think about the mindset of we actively search for these patients now, right? I always kind of say that we're looking for them now, not running from them now, right? And so because we can offer them a whole host of treatments, and obviously we're talking mostly about things like IPL, radio frequency, and in-office treatments today, but we also have a lot of medications. We also have a comprehensive suite of things now that we can utilize to help these patients, right? So I think that's the fundamental change,
Mhm.
is hear the patient out, listen to their symptoms of dry eye, ask the right questions to elicit some of those comments from them. Because if you just say, do you have dry eye, to a patient, they might say no. Just like if you say, hey, how are your contacts? Oh, they're fine, but maybe
Yeah.
we could upgrade them to a different lens. I mean, again, this
Yeah.
is kind of fundamental in your practice, but I think for dry eye, we're we're not used to probing and asking and trying to really elicit and find out if they have those symptoms. We're not screening enough for it. And then, once we do that and get comfortable with doing that and having those conversations with the patient, then you can really kick off your practice. I think that's really it.
Yeah, no, I appreciate that. A lot of times though, I do realize that, so I was speaking to a doctor recently and she said, I signed up I have a very high conversion rate at almost 90%. And I said, really? That's amazing. That's like really amazing. So tell me the numbers. And she asked, I was visiting her and she asked her staff member to say, give me the number of IPLs I signed up this year. And it was from January this year, 2025, till about October. I went to visit her in October and it was 32 IPLs. I said, that's it almost, that's it. That's like, what's going on? And I said, how many comps did you do? So she was only counting the symptomatic dry eye patients.
Yeah.
And when I showed her the numbers exercise like we just did here, and the potential is, because the thing is, I said, what about the ones, are you doing meibography? She goes, well, not really. Sometimes yes, sometimes no. And then I said, well, if you have 40% of patients walking in with dry eyes, that's your funnel. That's the funnel. It's not just the ones who are symptomatic, which could be maybe 50%. I don't know. There's 30%. I don't know. But if your funnel increases like this, if you do meibography and you see the ones who have gland loss, than just the ones who have symptoms. So talk to us a little bit about what you're seeing in your clinic in terms of potential for the dry eye business. Is it just the ones who are symptomatic? Is it a mix, or like give us that sense, that breakdown?
Yeah, no, it's definitely a mix. I mean, the ones that are symptomatic are going to be more of a slam dunk, right? That's where your conversion rate, if you just take those, your conversion
Yeah.
rate hopefully will be much higher.
Yeah.
There are a lot of asymptomatic, minimally symptomatic patients that are definitely out there. I wouldn't recommend necessarily that's your first few conversations that you have when you start out, but once you are screening appropriately, again, probing for some of those questions, some of those patients actually are symptomatic. They just didn't know how to tell you that. They didn't know that their contacts they should be feeling dry by 6 o'clock or 5 o'clock, in the afternoon. They just said that's normal. That's what I thought was normal. They didn't,
Mhm.
well, my friends have the same problem. Everyone has the same problem. We're all dry by 5 o'clock, so then it
Yeah.
must be normal, right? And so you have that aspect, and then for us we just screen, right? We screen with meibography for every single patient, and so when they come in, it's just part of their comprehensive eye exam. They get their Optomap, they get their IOP, they get, the autorefraction, they get a meibography, right? It's just
Yeah.
part of our comprehensive eye exam. And when you start doing that and identifying patients who have moderate, sometimes severe gland loss, and even some of those may be minimally symptomatic, but
Yes.
but they do deserve to know that, especially if they're young, that they have moderate to severe gland dysfunction or gland loss as well. We'll see sometimes these really tiny glands in these young patients, and let's talk about the fact that we need to preserve this and make this last for
Mhm.
however many 60, 70, 80 years, depending on how
Yes.
young they are. And so that kind of preventative aspect is really, really important. And it just helps the patient to understand and
Mhm.
make sure they're educated on that.
Yeah, yeah. I find that when we speak to doctors every day, all day long, who do dry eyes. One of the observations we've seen is that when you start talking to patients about symptoms, and then a price question comes up, how much is the IPL going to be? They tend to kind of play down their symptoms. Oh, it's not that bad. It's
Yeah.
like we tend to sort of delete and generalize and distort things based on if we think it's so expensive or not, and the other thing is that often we've seen when you present a meibography findings, it is the data talking. It is objective clinical assessment rather than just symptoms alone. And that is a big deal for people because dentists do x-rays all day long. Other doctors more and more are just relying on blood test, an x-ray, or a scan like a meibography. And so you're able to justify to the patient, look, I found something It's not right. It's not aligned. Something is going on. Let me investigate, do some more testing, and then let's get to the bottom of this. And that gives you, in a way, a little bit as a doctor, I've seen the confidence in doctors change when they start doing meibography and then they have that intelligent conversation. Have you seen that in your clinic? Because you now make it standard of care in your practice. And a lot of doctors don't do that. A lot of doctors are like, no, I'm going to do it with her. I'm not going to do it with him. And I'm kind of like, you gotta raise the standard of excellence. I don't know what you found. What do you find?
Yeah, that's exactly what I found. I think for me, like the best kind of analogy that I like for this is, I think at this point, standard of care is to, if you are able to, do some kind of imaging, right?
Yeah,
Screening optomap images or fundus photography or something, right, on everybody. Obviously, we'll take our, you know, indirect lenses and look inside, but ultimately some kind of screening photo and when we look at, I pull up an optomap and I look at that nerve and I'm like, oh, that's a little suspicious. That you see a little thin rim or a large CD ratio or something. And again, we've been trained on this, so we know that we then have this conversation with this patient, who, by the way, is completely asymptomatic, right? No glaucoma suspect
yeah,
is symptomatic in your chair. They're completely asymptomatic. They have no idea what an optic nerve is. They don't know what it looks like. But we're comfortable showing them maybe a normal versus theirs, or you know, drawing out a CD ratio, or whatever, whatever you use to talk to the patient. And then what do? We book them back for more testing, right? So we treat glaucoma suspects like this all the time. Maybe you see something in the retina and you want to have them come back for, they can't dilate, they can, come back for a dilation, or whatever you might see on your initial exam, we may bring them back to do additional testing, right? And again, in the glaucoma world or glaucoma suspect world, we're really comfortable with that, and we impress upon the patient. It's really important that we follow this every 6 months, or recheck your pressure. We've got to, follow you closely, make sure that you follow up on this. It's important, and so, dry eye is arguably
mm,
just as important and could
yes,
lead to similar issues with the patient later. I mean, it's certainly more uncomfortable for the patient physically. Obviously, I understand that the vision aspect can come a little bit later with dry eye, but absolutely. I mean, I see patients all the time with severe, it's referred in patients with severe dry eye. I mean, they're one of their biggest complaints is vision. It's absolutely vision. And so I think that's kind of my favorite analogy to kind of think about when you're thinking about how do I talk to patients? How do I do this? It's just think, well, I already do it every single day. I've been doing it since I graduated. It's like that's what I've been doing. But now let's think about what else we can screen for. And there's going to be other things, I think, as technology improves for our imaging, and then things that we're going to probably learn and we should be screening for. And so this is just one of those things. To me, it's just as important as the IOP, as the optic nerve, and all those things that
yes.
we test for all the time.
Amazing. No, I think it should be standard of care. I mean, that's one of the things we've seen across the country. And the most successful and most profitable dry eye practices, they have meibography as a standard, and it's in pre-testing. I went to a clinic once up in Boston, and he had that big my box or something. I forget what it's called. And it was on the slit lamp. It was like
Oh yeah,
draconian.
right.
It was
Yeah.
draconian. I'm like, bro, you're lifting that thing, putting that attachment, and dude, I'm like, how often are you gonna do that? I'm like, stop. I'm like, do it in the
Yeah.
pre-testing. I'm like, how often are you gonna do that? And you can't. You really have to do it in the pre-testing and then have it come up on your screen. And then you can have that conversation with the patient.
Yeah, that's the way I like to do it. We'd like to do it in pre-test. I know a lot of people have meibography on their slit lamps, and
Yes,
and and they've certainly gotten better. I think
yeah,
there's some slit lamps that build it in. There's little ones now, and I mean, look, I'm in New York City. If you have plenty of exam rooms in your
yeah,
big office and your techs take the patient in and then can do the picture for you in the exam room, great.
yeah,
For me, we don't have when we have 4 exam lanes in our clinic, which is pretty big for New York City. And but even then, exam room, the business thing, your exam room time is your
yes,
most profitable time you have. And
right.
so we want to do really as little as possible in there, because
Yeah,
otherwise we can't put another patient in, right? So
yeah,
so
yeah,
to me, yes, it should be in pre-test. But again, everyone
yeah,
can do it differently. And if you're a single doctor practice right now, I mean, do it and you're doing it in your slit lamp, great. I
yeah.
think just start doing it, I think is
Sure.
the most important thing. As you get busier, you probably
Yes.
want to have someone else do it, in the pre-test.
Agreed. We have a question here. Thank you, Sonia, Dr. Sheth here. Do you give patients a dry eye questionnaire? What does that look like? And then what is the dialogue you have with a potential Envision patient?
So we do have a dry eye questionnaire. The way ours works actually is, we do our intake forms digitally. And so if the patient, we have a little section on symptoms. I'm sure everyone has something similar, right? Do you have blurry vision? Do you have dry eyes? Do your eyes have burning, itching, redness, tearing, anything like that? So if they check off any of those options, then it'll pop out a little dry eye questionnaire. So we don't make every patient fill it out, but it'll pop out a little dry eye questionnaire. We kind of made up our own a little bit, but there's a bunch out there, like Speed, OSDI, DEQ5. You can look at them, pick them. We kind of took a couple questions from each, but they're all kind of similar. They ask about the severity of the symptoms, how often they have them, right? And then they give you some kind of score. And then that score will help you track that patient so you can repeat it later, or you can talk to them about that. So that's how we do it. Certainly if a patient is coming in specifically for a dry eye consult, then we'll make sure that they definitely get it. But that's how we kind of screen those patients. So we don't necessarily make everybody fill it out, because some patients like to complain about too many forms. But if they're coming back certainly for an evaluation, then we'll have them fill it out, in the
Yeah.
meantime.
Yeah.
Um,
Yeah, and then the
and
meibography should, like, if you do the meibography, then you can actually, hey, go more into symptoms if you need it to, right? It's sort of.
Exactly. You can always delve back into it. But if they are truly asymptomatic and the meibography looks good and the cornea everything looks good, then
Yeah.
on their comp, then yeah, we're kind of good to go. What
And the
was the
other part of
second?
the question, yeah, the other part of the question was, what is the dialogue you have with a potential Envision patient?
So it really depends on what we find ultimately on their ocular surface, evaluation when we come back. So, the dialogue really is based on the need, right? What did you find? So did you find MGD? 86% of dry eye cases have an MGD component, so you probably did find some MGD. So for me, that's going to help direct me usually towards using RF on the patient, so the former eye RF treatment, and then you do a really detailed slit lamp evaluation. Do they have and look at their face, right? Do they have rosacea? Do they have ocular rosacea? Do they have some type of skin inflammatory condition? Do they have like really, really small, glands? In which case, I'm going to use the IPL. So my dial is going to be based a little bit on what I find on the exam. Before they get to that point, they will already know what those technologies are, because we've already sent them some information on the treatment. So the patients are kind of coming in already prepped, right? That's kind of the big key, is I don't want to necessarily have to have that full discussion every time. The patient is already aware of the treatment options that we have for them. And so we will talk about what we found on the evaluation and then which treatments they should have, right? So that's kind of how we kind of direct it.
Great. No, thank you for that. I think one of the things that we see also is that a lot of times if you shift from, hey, I did a meibography, I suspect you have MGD, and then let me just talk to you about my, beautiful InMode Envision IPL and RF, it becomes a little challenging because you're trying to explain so much in one comprehensive visit, and it's just overwhelming for the patient. And so often patients are like, Doc, I just came in for glasses and eye exam. Well, what is going on here? I don't feel dry. And then you go down this rabbit hole of, well, it's, your image shows this. Well, it costs 2,200 or 1,600 or whatever. Well, insurance doesn't cover it. So sometimes it can be really overwhelming for the patient. Ideally, yes, you find something, you have the imaging to demonstrate it's a problem, it's going to get worse based on history. You do a thorough exam, and then you present a solution. But the problem is today, people are so overwhelmed, they're busy. And then when you have that, it's this clash of like, Doc, like, I got to get out of here. And then they say no. And that's really like, doesn't work. So one of the strategies we've seen, and I know you've done this before as well, and you continue to do this, Dr. Patel, is you bring them back for an ocular surface evaluation, which is where you have the conversation about the Envision, IPL, RF, where a lot of doctors, comprehensive, is really about the diagnosis, diagnosing the problem, meibography, this is a serious problem. Because otherwise, if you don't press on the problem, they don't pay attention. There's just like, I don't feel the symptoms. Like, why are you telling me to buy something for $2,000? I don't feel the symptoms. And my eyes don't feel dry, doc. In fact, they feel wet, like they're like teary, like, it's like, what? Like, so you're getting into that conversation and they think you're trying to sell. And I've seen so many doctors kind of panic. And then they're like, and that ties comprehensive visit. Well, it's great. It's great technology. And then they lose that patient. And one of the greatest books I've ever read, Story Brand by Don Miller, says nobody gives a shit about your solution. They care about their problem. And so the more we focus on the patient's problem rather than our beautiful instrument or solution, as much as I know it's a beautiful solution, it's great, it works, it's FDA, all and we spent 100 grand, 200,000 on it. I totally understand, but it just overwhelms the patient. And so the solution is really to bring the patient back for the ocular surface evaluation. And I think that's kind of worked. I don't know what's worked in your clinic when patients, especially in New York City. I mean, New York City, I guess, is a little bit different because there's some who's like, okay, doc, I trust you, let's go. Right. But then there's others like, I don't know what this is. I'm overwhelmed. What's your view on that?
Yeah, I would say the majority of our patients are coming back, probably 75 to 80%. Again,
Yeah.
this is if they are coming in originally for a comprehensive eye exam,
Right,
right? If
right,
they're
right,
coming,
right, right.
right, then 75 to 80% we're probably booking back for the consult when we're doing it. Um,
Yeah.
if and maybe even like if they're new patients to the office, right? If they've been a patient of mine for years, we may have had some conversation over time, or maybe their symptoms are now getting worse, whatever it is, that's a different story too. But the majority of, I would say, new comprehensive exams, and recent patients, last couple of years or something, we're gonna bring them back. Yeah, there's a handful in New York that are just, I've already
Not
had
doing
this
well.
conversation the last couple of years with other doctors. Just tell me what to, sure, well, I'll try and do that. But what I found is that then we're rushing. I'm rushing my speech because I know I've got another patient waiting. I know I don't really have the time for them, and it's the same patient that, wanted a multifocal refit and all the other things that we
Yeah,
just did,
right.
right? And so now they're like,
Right.
oh, what about my drug? And so we just don't have time. And so if
Yeah.
we're rushing with the explanation and not, then you really kind of doing the patient a disservice because they feel that, and then they don't feel like they can ask the right questions. They don't
Yeah.
feel comfortable. They're very uncomfortable because everything is rushed and quick. Right now, again, in New York, sometimes that works for some people, but for the most part, it doesn't. They don't have enough time to understand everything. You don't have enough time to really
Yeah.
talk about their problem and what's going on. And so we
Yeah.
really just bring them back, and I'm pretty strict about that with most patients. And
Yeah.
most patients are pretty much conditioned to it these days. I mean, if you go
Yeah.
to your primary care doctor, if you go to
Yeah.
I've heard stories from the patients when they're like, yeah, I went to my derm and you're allowed one problem, you know,
Yes.
you're allowed one
Yes.
problem to bring up to the
Yes.
dermatologist.
Yes.
If you have another problem, it's another visit,
Yeah.
and a lot of doctors are practicing in that way. Again, maybe not that extreme, but that's kind of how it is, right?
It
There's a
is.
certain amount of time that you have, and we've already done your whole comprehensive eye exam. We've done a million problems in that space, and now this one really deserves its own time. And so
Yeah.
just, I think don't be afraid to do that. It's standard of care in other fields. I think we're playing catch up there because we have this mindset of, oh, we do everything in one visit. We see the patient
Yeah.
once a year and we do it all in
Yeah.
one visit. That's just our mindset, right? And it's really not the medical mindset. That's not how the medical mindset really works. But I
Yeah.
think we have to shift a bit to that.
I really love that. It's that mindset piece. We had a doctor, Houston, and she's terrific. And she said that, Bob, I know you tell us don't cram the comp. That's kind of, I wish I had a t-shirt, don't cram the comp. And she said, I did. Patient was in my chair. She's a paralegal. She had dry eyes, MGD, and so she said she talked to her about her IPL. Patient said no, went home, wrote a 1-star negative Google review. The doctor sold me $700 glasses. Then she told me about a disease that I'd never heard of before. Then she magically had a solution for $2,000. Don't go to this doctor again. She's money hungry. I mean, it's ridiculous. It's absolutely ridiculous. It's
Yeah.
unfair, but this is the kind of mentality patients have when they feel rushed. I mean, Dr. Patel, you mentioned you're rushed, of course, and you want to give good service to the patient, but the patients feel rushed and they feel rushed to make a decision and a choice which they have to go home and justify with their wife or their husband with, like, honey, what happened to the doctor? I dropped 2,000. What? You dropped 2 grand on what? You never complained about dry eyes, honey. How come you? I don't know. I don't know what I did. And then they get buyer's remorse and they get really upset. So having them come back is really, really powerful. But the one thing that I want to mention, I mean, we do this just huge, just, I mean, I don't want to make it like a promotional thing, but one of the things we found very useful is, and again, I just show this for just sort of for illustration purposes, but this is Dr. Patel's education. So basically, you know, you come back after a week and the videos of Dr. Patel or yourself or whoever go to the patients over drip, drip, drip. It's what is MGD? Why should I care? What if I do nothing? What are the treatment options for it? And they show up pre-educated. So this goes out automatically. These videos are pre-shot, and this is a medical assessment report. It's a summary of what happened. And what that does is that's helped a lot of physicians and practice owners and dry eye, successful dry eye practices to educate the patients at home. Because what we don't want is patients to kind of forget about it and forget about us. You touch them. Now there's an opportunity to educate them over the course of the week. And I think that's been very helpful for a lot of practices. I don't know what you think, Dr. Patel, but one of the things we've seen is it's really about trust, and you earn that trust with education. So I don't know if you found that useful or not in your clinic.
Yeah, definitely. And that's what I meant about, they're kind of coming in prepped because they'll get those 3 videos before they come back. And so they're kind of ready to have the conversation. They actually understand. They know what a meibomian gland is. They know what the 3 layers of the tear film are. It's so
Yeah,
they come in and it speeds up your explanation. You can get really to the point of the explanation, and so
yeah,
you save a lot of time, first of all, in your evaluation, right? Because the other thing, and I do quite a bit of speaking on dry eye, and I talk to doctors all over the country, and they're always like, well, how do you do it? How do you fit it in? It's because you've got to give them something to learn at home, right? Because if you
yes.
try to have the physiology conversation every single time, it's
I
gonna
agree.
you're gonna get bogged down in that, and then we're not really getting to the solving the problem part, right? And so um so the pre-education is great. I mean, yes, we use Hoot, but I mean, in the past we had pamphlets and some other things, but we didn't find them super effective. I mean, honestly, we would give out a dry eye sheet and they would like leave it in the waiting room. We'd find them in
Yeah,
the optical, we'd find
yeah,
them, all over the place, right? And so,
yeah, yeah,
so we just found that the more direct, like direct to their hand,
yeah,
is just the way to go. And so when they come back, they already know that we're going to offer probably in-office treatments. We're going to offer maybe some home treatments. They know that in-office treatments are generally not covered by insurance. They know that, so, it takes all of those things kind of out of your spiel when they're,
yeah,
when they're there, and you just focus on them, right? You really look at the results, go over the results with them, show them their imaging, show them whatever imaging you're going to take, pictures you're going to take. We do tear breakup time, we go over that, so I go over some of those details to kind of confirm our diagnosis, and then offer them the treatments that we're going to do,
yeah.
whether it's medications, whatever combination of
Totally.
things that they
Yeah,
need.
yeah,
But we're kind of getting more to the point, right, of the
yeah,
visit, instead of spending too much time giving too much, history
yeah,
lesson
no,
of dry
yeah,
eye, and this way they're just ready to go. And so we found it very, very effective to do that. And I just found it to be great because I don't have to have the same conversation 10 times a day. I
yeah.
mean, all the same, basic science conversation 10 times a day.
You can't scale a business that way either, right? If you're constantly saying the same thing over and over again to different people. There's a question here, Dr. Patel, from Dr.
Yes.
Sonia Seth here. Do you schedule treatments on days you see comprehensive exams, or are you dedicating a specific day just for treatments? And then the second part of the question is, how do you have the text do the former portion since it's 10-minute per eye, and you do the expression IPL, or do it all by yourself? So there's two parts to the question here. So
Yeah.
now getting into treatment.
We basically do a combination of both in terms of scheduling. We do schedule treatments kind of throughout our schedule. And then my Wednesday was really my kind of admin day in the office, but we just ran out of space to put patients in for treatments, and now I do some treatments on Wednesdays too. So I don't see any other clinical patients on Wednesdays, but I do have like a reasonably full schedule on Wednesdays of treatments. So a bit of both. Try what works for you. The admin day thing actually has kind of worked quite nicely, just because I'm not kind of rushing as much between patients. But then during the comps, kind of leads to your second question is yes, the technicians do the former eye treatment. With the InMode RF, it's so safe to delegate to your staff. So as long as you have a competent technician, they really would have to struggle to hurt a patient. The safety cutoffs are there. The energy is locked in, at a very
Mm.
shallow depth, and so the technicians do that. So I'll do the IPL myself. I like doing the IPL myself. And then they'll do the form on one eye. Then I'll go in and express, and in that 8 to 10 minutes, I can see a patient. So I'll see a patient in between that time. So yeah, we kind of treat it like it's almost like you're going in checking a dilation. You go in, do the expression, go out, go back in. And kind of do it that way. So the technicians help out a lot. An IPL only takes me you know 5 to 10 minutes at the most if the patient's kind of ready to go, and even if we're doing a full face treatment. So yeah, I like doing the IPLs myself. Some of this is also state dependent. Some states are a little more lenient with delegation compared to others, so just check on that with your states. But form I is really safe, so you should feel pretty comfortable delegating it. Just train your techs well, but you can definitely delegate that.
Great, thank you for that. I'm going to drop in the chat another perspective as well. Dr. Corey Langford, who we work with, he's out in Nebraska in Omaha, and he has his techs do everything. Basically,
Yeah.
they're really well trained, as yours are, and he just goes in and sometimes he expresses, but and he goes in, and just talks to the patient, but essentially the techs do everything. And his techs, he was very lucky and he found really good techs that were really interested in doing more dry eyes. And so I'm just going to drop the thing here. If you guys want to take a look, well, we had him on a podcast a while ago, but like he kind of figured it out. The goal is to try a little bit here, try different things.
Yeah.
I think that's the most important thing. So let's talk now. Hopefully that was helpful, Sonia. If you please do ask more questions. So what doesn't work, Dr. Patel? Give us one thing. We talked a little bit about the meibography, talked a little bit about bringing them back, having a thoughtful education conversation. But what do you see that practices do, optometrists do, that does not work for creating a dry eye business?
They don't involve their staff enough. So staff
Mm.
is really important. You need your staff on board. You need your staff aware of the treatments you're doing, what they're doing, because they're going to field the questions, right? Before they come in, after the patient comes in, they're going to field the questions. So make sure that your staff are up to speed. Treat your staff, get like these technologies really work, right? So treat your staff, get them on board because they feel better, they look better, if you're
Yes.
doing IPL on them,
Yeah.
or even some, RF around the eye,
Yeah.
get your staff on board, get them excited, right? I think that really helps. And it almost helps you stay accountable a little bit too. I think if your staff are really like, you know, this is so great. Why aren't we signing up for patients for it? Then you better figure out the rest of it. So I think that's really important. And then, the other thing I think is just rushing, it's just rushing through. And again, I don't mean spend an hour with the patient, but rushing the whole process. I think we kind of touched on that already, but don't cram. Yeah, I like the don't cram the comp. I need that. I need one of those t-shirts when you make them. Yeah, can I get one? But don't, I completely agree with that. I think it's just don't rush to do everything
Yeah.
too quickly.
Yeah.
Build the list, start with and also start with the more symptomatic patients. Start with the patients that if you've been in practice for, 10, 15 years and you've got that patient that's been on Restasis for 15 years and every year they come in and say, hey, do I still need this? And, maybe take a closer look at some of those patients because they're waiting for you to
Mm.
offer them the next solution, right? Just
Yes.
just like you should offer them a newer, maybe offer some of these patients a newer contact lens, a newer daily came out, or they're looking at you. So what really doesn't make people successful is not talking about it enough. Talk about it. I think, and it's the same with myopia. Myopia in my mind is the same thing. I mean, if you have that pregnant patient, if you have that, you mention it. If they're a -8, hey, do you have any kids? It's really important to talk to your patients about these
Mm.
things, and because the more awareness you bring to it, the more, sometimes have a conversation with a patient and say, yeah, you know what, you may have, your eyes do look a little bit dry, or, and they're, yeah, you can kind of tell that they're just like, yeah, I think, I'm okay, whatever, so they don't want to come back, fine. And then, a couple of years later, that patient said, you know what, when you told me a couple of years ago, I've been thinking about it, and you know what, I do feel dry, they'll come back, or they'll call months later sometimes and say that, and so just educate the patient. Again, I know that's our kind of theme tonight, but
Yeah, yeah, yeah,
but just tell them that there are things available. There's
yeah,
been changes in technology. There's changes in, just like you might offer them a new medication or new
yeah.
new contact lens. This is something new. Start with those patients, get some treatments under your belt, and then grow from there. I think that's really the kind of key to it. Instead of trying to tackle, again, you definitely can tackle the asymptomatic, but I would definitely be more comfortable just getting to those. But I think there's a lot of you know easier options at the beginning. We all have them in our practices. There's tons of patients that are always waiting for you to say to them, hey,
Yeah,
we
yeah,
have something new that could really help you,
right.
and that just opens the whole conversation up.
Yeah, we found that in opening up the conversation, one of the things we found that we asked doctors, okay, tell us what you say, and you've got a very good pattern down, Dr. Patel. You're very good at sort of doing this thoughtfully, but a lot of doctors are like very confused. They're not confident in speaking about like, okay, let me tell you something new. They feel like they're kind of selling or pushy, and it's not the case. It's really giving value to them, to your point, or like educating them. So what we did was, one of the things we did was we found that if we just left doctors alone to their, it's sort of, they go up and down in terms of their state of mind. Depending on the state of the mind they're in, determines the script they would use to talk to the patients with. And that really doesn't work. And so what we ended up doing, a lot of doctors asked us, create us a script. So we created this three hats talk track, three hat strategy. The first hat is the doctor hat, where you make the diagnosis. The second hat is the educator hat, where you say, Mrs. Jones, let me educate you about why you have this thing called dry eye disease or meibomian gland dysfunction. And you talk a little bit about the tear film, gland loss, and screens, okay? Talk about screens. And the third hat is what we call the mind reader hat. And the mind reader hat, we found that when you proactively answer questions that the patient thinks about, you build that trust and relationship as an expert that you are. So I know I've seen you do this before. It's like, you're probably wondering, why can't I just use drops? And the answer is, yeah, drops can be helpful for symptomatic relief, but it doesn't get to the root of the problem, which is your glands are clogged and they're just with hardened oil. And the only thing that's really going to do that is the Envision, the InMode and the treatments like that. You're probably wondering, Doc, why come my eyes I don't feel dry? And the answer is, you're right. You may not feel the symptoms until it's often too late. And one of the things we found really useful, believe it or not, was comparing it to high cholesterol, hypertension, diabetes. Today, most disease is asymptomatic. It's all about inflammation. And so we only pick that up in a blood test, x-ray, or scan like we did in your eyes. So that language, the three hats, really helped a lot of our practice owners to really become more confident. I mean, you're a pro, but a lot of these practice owners just started getting into dry eyes. They bought this machine, they're sitting there, and that three hat script works really, really well when you execute on it. But I'm just wondering, like, a lot of times there are objections that come up, Dr. Patel. So talk to us a little bit about, give us some tips just as we close up here in the next few minutes. By the way, if you're in the audience, please drop your question. We're going to close up soon. We want to be respectful of your time and Dr. Patel's time. So Dr. Patel, give us like a couple of tips on handling some objections that patients have that you think they're hesitating and they haven't, gotten, they haven't gotten the understanding that you want them to. What are some of those questions and how do you handle those?
Yeah, by the way, I'm confident now, but I wasn't when I first started, right? So we all went through the learning
Yes,
curve, right? But
yes,
the objections, yeah, look, there's always going to be objections. And are we going to convert every single patient? No. Are we going to land our message with every single patient? No, you're not going to, right? So first of all, be okay with that, right? I think you have to be okay with that.
yes, yes,
Again, this is part of um, having the conversation and widening the number of people that you're screening,
yes,
because not every, you know, conversion is going to happen, right? So if you limit yourself at the beginning, I think you've talked about the funnel, Bob, right? I've heard
Yep.
you talk about the funnel, right? But so
Yeah.
the bigger funnel
Yeah.
means that you'll still retain some of those patients at the end, right? So
Right. Right.
don't be afraid of that, first of all, right? I think that's something. But the main objections, I think that we come across, is obviously going to be around, sometimes we'll hear about cost, right?
Right.
A lot of these patients, I just saw a patient today that was prescribed, serum tears for, from another doctor. And she's like, this is so expensive. It's like hundreds of dollars every time and then she's like, but then you said I can do these treatments and it's going to help my oil glands, and the serum tear is not even helping my oil glands, but I have an oil gland problem, and so,
Oh, wow.
the alternatives there are, expensive for a lot of patients. I mean, I think we all go through the PAs and all the other things with some of the, and sometimes these patients will call and say, why is Restasis $400? So cost is relative, I think, um, but cost isn't always the main, it's really not the main objection that we have. Sometimes it's time, sometimes it's, there's a little bit around like, well, if insurance doesn't cover it, is it legitimate? I think you get a little bit of that feel from patients, but a lot
Yes.
of patients are understanding now that newer technology, newer treatment, I always kind of say, well, this technology came from the world of aesthetics, and you are going to get some of those benefits. We always mention those benefits to the patient that they're going to get when we do a dry eye treatment, which really helps them to kind of come around
Mhm.
the idea of doing it. And they're like, well, it's going to help my dry eye and
Right. Fine lines
help
and
my skin and my
wrinkles.
fine
Yeah.
lines and wrinkles, then I'm going
Yeah.
to do it,
Right.
because they're already paying for these treatments elsewhere anyway. So if they
Yeah.
can justify doing it for their dry eye and then getting those benefits, that's always helpful. So that helps with some of the technology piece of, these things are not covered from the derm aesthetic side of things. And so, we kind of handle the objections that way.
Yeah.
Cost, again, I think is a relatively low objection if you've been able to educate the patient
Yes.
where they
Exactly.
can make a confident decision. They are paying for all kinds of treatments. They're leaving your office and going down the street to a med spa and getting, facials with IPLs and Botox, and they're doing it because they want to look better. They want to prevent
Yeah.
wrinkles, preventative Botox. Like so many of my patients, you can put that question on your intake form and you will be surprised at how much these
Yeah.
patients are spending outside of our office, right? So I think cost is actually not that big of an objection relative to just understanding the problem and the dry eye, issue and what that impact's going to have for them, later. I think
Yeah.
that's the main thing.
Yeah, yeah, I agree with you. I think if we think about cost comes up and it's because we've kind of, crammed it and kind of said, okay, and we haven't given them value and we haven't given them education. So education to me, trust, we realize that doctors, they get these signups for dry eyes. Your InMode's going to hum when three things happen. They like you, they trust you, they think you're an expert at solving the problem they have. And the problem is we try to close them to compress that visit, and you've really got to lengthen that journey. I think that's really important. And the second is that, when you talk about other things patients are doing, Botox could be one, but very simple things. I mean, there's from progesterone to testosterone
Yeah.
in men, supplements, the money that's spent as a father of two daughters, okay, and a son, a young son. I can tell you the nail bill, getting their nails done at the salon, is outrageous. It's outrageous. Okay. And the amount of basketball tournaments my 10-year-old son has to, like, it's insane. The money that's being spent on so many things. And then for me, as a 55-year-old guy, I do testosterone. I started doing testosterone shots because all my friends are like, what are you doing? You're not doing it. Well, you got to do it. And take NMN, and you got to take this, and you got to take this. My supplements bill, I kid you not, I have like a thing, pill box. I have a pill box. Okay.
Yep.
I have a pill box Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, morning and night, from minoxidil and finasteride for my hair and a statin to during the day, metformin, more and more. I'm not diabetic, but I heard it's a longevity drug. And so, Shafai's, my wife is the expert on the longevity. There's a whole longevity boom, and we don't realize it. There are more people spending money on longevity than ever before. And I think if you talk in that mindset of want your eyes to be healthier in the long time, because you're not just living to be 70, 80, 90, easy, easy.
Yep.
And when you do that in that context, plus the fine art is, it's a no-brainer. So it's really about education and bringing the context to the conversation, not just saying, hey, I got this beautiful instrument, let me put it over your eyes. You know, that's not what it's about. So I think you're 100% right, is to give patients that broader perspective, the number of Botox, I mean, there's people are on so many different drugs today. It's kind of crazy. So I think that's very helpful. Talk to me as we close up here, I guess. Any other questions, by the way? This is terrific. Thank you so much for your time, Dr. Patel. Just last, I guess, 1 or 2 questions here. If you were to, you know, kind of, if you were to go to somebody, someone says, hey, Dr. Patel, accelerate my dry eye growth. What would be the thing or 1 or 2 things that would really accelerate their growth in their clinic?
Screening meibography, number one, absolutely. And then figure out the patient education, so, if you want to
Yeah.
design up your own pamphlets and things, that's great. If you want to do that, that's fine. Obviously you can call Bob. He'll plug you into who, get you started, you shoot your videos and you educate the patient. I mean, honestly, it's you've got to educate the patient effectively. So just figure out how you want to do that. There are obviously solutions available for that. If you want to figure it out yourself, that's fine. But you need something quick, easy that you can do that's preset and ready to go. So, it goes to the patient. You don't have to worry about it. The patient comes back for the evaluation, and then that's where you're gonna lift your dry eye practice. You need those few things. The screening is super important. And then the education, you have to deliver lots of education. They have to understand. You want them to be educationally intelligently invested in the treatment, not financially invested. They will be that too, but they need to know that why they're doing the treatment, what it's for, how it's going to help them, and what it's really doing for them, right? And so we've got to get that across to the patient, and that's really the key.
Yeah, no, I love that. The meibography is very important. Education. What's really, I think one of the other things that I just want to share real quickly is that when you educate the patient, you also have to remember you're educating their spouse at home, right? So when often you finish the ocular surface evaluation and they go home to go think about it and book the treatment, they're going home with the knowledge that you gave them. And sometimes the knowledge is like, honey, what happened today? I went to the doctor. Oh, he told me I have to do this, procedure for dry. What are you talking about? Do you have dry eyes? No, I don't have dry eyes. What's the procedure? Like, that's the one conversation. The other one is, which is what we want, which is, honey, what happened today? Oh, doctor scheduled me for dry eye, an IPL procedure. What's that? Oh, my glands are clogged because I'm on screens a lot. And they had a x-ray thing and they took a picture and they showed my glands are clogged. So like, this is a real conversation between a husband and a wife when you go home. So what does the doctor want you to do? Oh, he wants you to do this procedure. Oh, by the way, here's the phone that shows what the procedure looks like. So you text them that video about the Envision, IPL RF, and then they're aware of it. And so the husband and wife conversation takes place. And then the wife or the spouse says, okay, that makes sense. I trust him. He sent you all this stuff. And he's a very good doctor. He takes good care of it. He spends time with me. That is what determines success, is you, the doctor, reaching that other decision maker, healthcare decision maker at home. Because what we found is that healthcare decisions are made in the kitchen today. They're really, really, people want to talk to each other to figure out whether this is, happening or not. I'll give you a simple, another analogy. I have tetracycline stains in my teeth because I was born in India. I had tetracycline, I had pneumonia when I was a kid. And we go to a dentist for a veneer consultation. And I went in and 6 o'clock or something PM. And he shows me 20 minutes of book. And then I asked him 1 or 2 questions. And then we go to the treatment coordinator who presents me an invoice, a treatment plan, $33,000. And I'm like, is this like, are you kidding me? Did you make a mistake? And then I said, pay for my kids' tuition in college or get my teeth fixed. I don't know. So I'm like, okay. And I go home And my wife, the smart one in the family, the optometrist, had like 8 questions. She's like, well, what about this? What about this? What about this? And I had no other materials from the dentist to justify the cost. And that is a big problem. So today people kind of want to like stew on it, think about it, and chew on it a little bit. And that's where really education matters. What you say in the exam room, really important, Dr. Patel, certainly. And also when you send them home with is really important. So that's really speaks to the world we live in today, how people make decisions. And it's not the old days where you told them exactly what to do and they did it.
Yeah.
It's now where there's a collaboration,
Yeah. Well, the best one is then the spouse makes an appointment, says, well, maybe I have dry eyes, and so because
Right.
so that always is a
Yeah.
nice benefit too.
Yeah. Last question from somebody here. Clark Weeks, thank you for that question. Do you perform meibography during the comprehensive exam or during the dry eye workup on the second visit?
Well, kind of both. So we do lower lid, quick lower lid meibography screening during the comprehensive exam, or in the pre-testing for the comprehensive exam. So lower lid, quickly pull down the lid, take a quick picture. That's all we do there. And then when they come back, and sometimes the techs are kind of instructed to, yes, we want to get good images, but they don't need to be absolutely perfect, as long as we can get some decent image on that one. When they come back for the evaluation, we do a little bit more detailed imaging. We try to get make sure we're getting the full lid, make sure we're getting upper and lower, and do that on the second visit. But the lower lid meibography, I spoke to some doctors who are doing, just one eye, meibography screening. I just like to do both, because then the patient says, "What about my other?" Yeah, so we like to do the quick lower on both. It takes them just a couple seconds to do it, and then the upper and lower on the follow-up.
Perfect. All right, we're going to close it up. Dr. Patel, I want to thank you for your time. It's been really, really, really helpful. Learned a lot of good tips. We'll have this video on, if you want to just look at the URL, we're going to have this on this URL here. It's to go to gethoot.com and /events, and you'll see Dr. Patel's talk here when you go into it, and you'll see tomorrow. The video will be here. Okay, so for that. And by the way, anytime you want to look at other events, you can go to gethoot.com /events. My name is Bob Miglani. Just give a little thumbs up or a like, or give us a sense of, did you like this talk? Did you appreciate it? Did you, little applause for Dr. Patel for spending his Monday evening with us. So yes, wonderful, great, awesome. Yes, thank you so much. Got some hand, some movement here. Dr. Patel, thank you very much for your time again. Anything else you want to say, Dr. Patel? Are we good? What do you think?
No, I think that was a good conversation. I think start thinking about this in your practice. I don't know, the people that are on, I'm not sure what stage they're at. Some might be thinking about adding this to their practice. Some might be already working with it, trying to grow it. Some might be, experts. I'm not sure, but hopefully it was valuable. You got something out of it, and please feel free to reach out to, myself or Bob if you have any questions.
Thank you very much, everybody. Have a great night. Thank you so much for your time. Great to see
Good
you.
night.
Bye-bye. Good night.